Queer and trans life is inherently connected to questions of social justice. There is no I'm not political if you're a queer or trans person today. This podcast is a place where we explore those conversations. Hi, I'm Zef, a Chicano illustrator from Southern California and an Aquarian, and you are listening to QT Life with Rainbow Pride Youth Alliance. Hey everyone, this is Zef, and you're watching QT Life with Rainbow Pride Youth Alliance. Today I'm joined by Dr. James Simmons. Dr. Simmons is a nurse practitioner with a doctorate in nursing. He is also a lecturer at UCLA and a public health communicator under the handle Ask the NP on YouTube and on Instagram and other platforms. Among his accolades and titles, he's the advisor for the Advocates for Prevention, Access, Intervention, and Treatment, or APAIT, and also an advisor for Black Queer Town Hall, which is a nonprofit organization run by About the Drag Queen and Peppermint. Dr. Simmons is also an ambassador for the Centers for Disease Control's Let's Stop HIV Together campaign. Dr. Simmons, thank you for joining us today.
Thank you for having me. I appreciate it. I have to also say, this is my thing. Someone told me the other day I have to say this more often. I was in one of Beyonce's videos.
That's right, yeah.
Which is why I still have the silver nail polish because,
Tell us about that.
Renaissance. I happened to be at a wedding the night that Break My Soul came out. And so the next day, the wedding also, this is not a flex, but the wedding happened to have like an actual supermodel at it. And so people were like, take pictures. And she was like, how about I take pictures of you guys? So we all went out on the beach and we were like standing there and the water and the air was blowing and I was in a dress and I was looking super cute in my heels and whatever. And it was a great video. And then that night, Break My Soul came out. So I was like, I put them together. I put Break My Soul on social, on Instagram, and the video kind of took off. And Parkwood Entertainment, like her production company, found it. And just slid in my DMs and they were like, hey, can we use this? And I was like, sure. So 6 months later, it showed up in one of her videos and there I was.
Wow, it was meant to be.
I guess. Everyone asked me if I know Beyonce. No, I have not met her. I don't know her. I probably would have passed out and died.
Well, there's a connection there.
There's a connection.
Okay.
She has at least seen a video of me at one point in time. Yeah.
Cool. God bless.
Yeah.
So I want to talk about public health. I want to talk about compassionate care and healthcare. I want to talk about these important things. Mm-hmm. But first, I wanted to talk about talk about sex a little bit because as the NP, part of the premise of the channel is that you're breaking down these barriers that exist in healthcare. A lot of people don't feel comfortable talking to their providers, and that barrier needs to come down. You've played a big role in doing that. Your work is symbolic of that effort. And so I wanted to talk about just sex in general. We're talking a lot about queer people, about men who have sex with men specifically, but just in the queer world. So I remember growing up, let's say like late teens, early 20s, you would meet older gay people, older queer people, and they would kind of pass you down wisdom. This was wisdom that you couldn't get from your elders at home, say, because your parents were straight, like they didn't get it.
Right.
So some of the wisdom that young queer people get is from queer elders. Sometimes it's sexual, sometimes it's not. But I'm gonna mention a few that wisdom that was given to me. And I would like for you to provide your perspective as a healthcare professional.
Is this officially me becoming a queer elder now?
I mean,
very excited
maybe.
about that's good though. I love it. Because I was taught by some incredible elders. I kind of grew up, my gayness, queerness was in the leather community in Chicago.
Okay.
At a very young age, at like 20.
Very cool.
So I like grew up, definitely had father figures, daddy figures, if you will, who were literally teaching me about like queer sex and about like staying safe. And this was 100,000 years ago, before there was PrEP, before there was whatever, like barrier protection was our only jive. So I am happy to now be stepping into my four queer mother, father footsteps.
Very cool. Chicago in the 90s.
Yeah. Late 90s, early 2000s. Yeah.
That must have been really fun.
Yeah. It sure was.
Well, because the music scene, I mean, Chicago's like the birthplace for like one of the birthplaces of house music.
Like legit house.
There was the late 90s and early 2000s was a really special era for that music, which is, super long standing, like over 30 years. But that era specifically produced some really beautiful music.
Frankie Knuckles, Ralphie Rosario.
Yeah.
I literally have been at house parties with Frankie Knuckles spinning. Like that was
So
that was way back. That was in my teens even. Yeah. It's a lot. It's very cool.
Okay, here's my question though. Okay. So one of these pieces of wisdom was spit or swallow, don't let it wallow. And so the implication here, like what this saying suggests is oral sex, if someone ejaculates in your mouth, spit or swallow, don't let it wallow. The suggestion being that your risk of STI transmission is low so long as you swallow it or spit it out, don't let it hang out in your mouth. What do you think about that?
I think there's some validity to that. Absolutely. So obviously if you just think about this from you don't even need to have a scientific perspective about it. But if let's say someone that you are playing with ejaculates on your shoulder, you have skin as a barrier there, right? And as long as you don't have a cut on your shoulder, your risk of contracting an infection that person might have is essentially zero, right? In our mouths, because of flossing, because of food we eat, because of just them being our mouths, this mucosal layer, so that like all the wet, juicy yumminess inside of your mouth actually gets cut and has microscopic cuts in it all the time that we don't even think about. Well, if someone comes in your mouth, you spit it out, okay, there's less volume of semen in your mouth that could get into one of those cuts and then give you an infection. Or if you swallow it quickly, whoosh, goes right down into your stomach acid, digestive system, etc. So there's some validity to that. Now, at the end of the day, it is not going to prevent if someone has a raging case of chlamydia or gonorrhea or something, and they ejaculate in your mouth, you're probably going to get it, which is why we swab your mouth, specifically your throat, right? For those things. So when you go get checked, you should get all of your holes checked, right? Whatever holes you play with, mouth, urethra, butt, vagina, if you have one, whatever, right? Get all your holes checked.
Yeah.
So there's something to that, I suppose, but I also want to make it explicitly clear that people don't lean on that as like a prevention method to help prevent specifically chlamydia, gonorrhea, or syphilis. Now, HIV, we know, can transmit through oral sex, but it is exceedingly rare. Very, very, like we have a couple dozen maybe cases since the virus was discovered in 1981, right? It is extremely, extremely rare.
Yeah. Okay. Oral hygiene is important too, right? Because like if you don't keep good oral hygiene, it's likelier, for example, that let's say you never floss, your gums become more vulnerable, and then let's say one day you do floss, they're likelier to bleed and stuff.
And then they're bleeding. Yep.
So your exposure to whatever it may be that goes in your mouth becomes more of an issue, I imagine.
Right.
So good oral hygiene.
Brush your teeth, floss your teeth for safer sex, I guess.
Sure, yeah. Or just there's lots of benefits to keeping good oral hygiene.
Yeah.
Speaking of which, I think this is another piece of good wisdom, and it's not as funny, but what is it? Exposure does not necessarily mean transmission. So if you're talking about STIs, you can be exposed. That doesn't mean that the STI will be transmitted necessarily. There's a number of factors that go into play. Could you talk to us a little bit about that?
Yeah, I really love that point. And it kind of piggybacks off of, what we just talked about, spit or swallow, don't let it wallow. So we talk about like viral load in terms of HIV. So if a person who has HIV infection has a really high viral load, meaning they just have a lot of virus in them, it's easier for them to transmit that to somebody else. Just like in the opposite sense, we talk about U equals U, right? Undetectable equals untransmittable. So if you are a person with HIV infection and you have an undetectable viral load, meaning we check your blood, we don't see it in there, we cannot detect it, undetectable, you can't transmit HIV. So that concept then, if you think about, okay, a lot of an infection means it's easier to transmit to someone. Little or no infection means it's harder to transmit to someone. So if you are exposed to someone, you just come in contact with it, one of the biggest factors is how much infection does that other person have, right? So I frame it around HIV because that's one that a lot of people are at least starting to understand.
Sure.
It's even like COVID, for instance, right? One of the biggest factors about COVID is time under exposure. So if you walk past someone on the street who has COVID and they cough in your face, but you're outside, you're walking past them, you keep going one direction, they go the other, likelihood that you're going to get COVID is probably pretty low. If you are sitting in a room with someone who's got a ton of COVID, a really active infection, there's no ventilation whatsoever, and that person is just breathing on your face for, 2 hours, you're going to get COVID, right? Similar concept when it comes to sexually transmitted infections, right? So if someone is like, I have secondary syphilis, this thing's been going on for a while, it's never been treated, that person may not even know they have it, by the way, and you're having they ejaculate on you, in you, whatever, and you're just having a good old time with it, it's longer exposure.
Okay. Let's say so that's a good point to make as far as, let's say syphilis. You can have syphilis or be living with syphilis and not know it, be asymptomatic, but still pass it to somebody else.
Mm-hmm. You can't. Yeah. Okay. So it depends on the phase. So there's sort of medically, we talk about 3 major phases of syphilis. Primary syphilis being the big one that we really talk about. So primary syphilis, about half of the time people have symptoms of that. So classic symptoms, sometimes belly pain. Sometimes you can have, the medical term is exudate, but pus or something's coming out of you, like out of your urethra. Yeah. Usually. So you can have some of these symptoms. You can almost feel kind of tired, malaise. That malaise is like, meh, I don't feel like getting out of bed, right? That's good.
Like more than normal.
Yeah, more than normal, right? It's how the world is these days. So primary syphilis, and that's the one where you see the billboard, syphilis explosion, and there's syphilis everywhere, and there is syphilis everywhere. It's wild. Yeah. But about half of people don't have any symptoms whatsoever. If you don't catch primary syphilis or treat it, it kind of goes dormant in your body for a while, and it pops back up a few months later with some other types of symptoms, and that's what we call secondary syphilis.
Oh, right. Yeah, syphilis is really consequential if you don't get it treated.
Very much so. Because if it moves on to that third phase, tertiary syphilis, that's the medical term. So third phase of syphilis, that's where people used to go. I know this is not a great term these days, but go crazy, right? Yeah. They would start having like hallucinations, start seeing things, start having personality changes. They would go blind from it. People who can have children or reproduce were having major reproductive issues. So yeah, syphilis is kind of a big deal if we don't really stay on top of it.
I always think of, I don't know how true this is, but medieval explanations for people having issues, and it would be associated with possession or magical reasons. But often people had syphilis and they just didn't have any treatment options.
Correct. Yeah.
And then it would take a big toll. Sometimes it would be fatal back in the day, right? Before there was treatment.
There's lots of historical figures. It can be. Yeah. We almost never see that now, but there are lots of historical figures who they're like, oh, this person went crazy or was, insane later in their life. And what we now are able to look back at and say, oh, those match up perfectly with what the symptoms of third phase syphilis looks like. This person probably had syphilis. So like I think Nero and Roman history, right? I think is one of the most famous ones. Don't quote me, I could be wrong. But who, because Nero was just having sex with everyone all the time, right? And then like Nero went crazy later in his life and they're like, oh, that's probably was syphilis.
Interesting. So I want to read a quote because we're talking about sex. We're talking about risks associated with sex, but I want to just contextualize a little bit and mention that, like with any activity, we take a risk and it's measured because we want the reward, right? And the reward of sex is joy. Like as human beings, that's really important that we have that connection. We establish and maintain social bonds. And so that's the importance of sex. That's the function of sex. So Edward Wilson is probably one of the, if not the most highly regarded biologist of the 20th century. And he has a quote from his book. It's called On Human Nature and it was published in the 70s. And he says, Edward Wilson, sexual practices are to be regarded first as bonding devices and only second as a means of procreation. I wonder if you have any thoughts on this quote.
So completely opposite of how we were raised, at least in the United States, right? I grew up in Nebraska in a religious family.
Okay.
So if you think about the puritanical roots of the like imperialization of the United States, of like the Western world, driven by religion, that is completely opposite of what we're taught, right? Sex is first and foremost for procreation, right? That's what we're taught. And then afterwards, it is almost specifically for the cisgender man's pleasure, right? If you think about even like porn, even porn that features women is still dick focused. It's still phallus focused. It is still ultimately focused on the person with the penis having an orgasm.
Yeah,
right?
through the male gaze.
Yeah, correct.
Yeah.
That's an excellent way to put it. So this is our framework for, as a society, how we think about sex. And that is, well, we know we need it to continue the species. And that seems pretty important.
As if that was an issue. As if,
that was an issue, right? Because 8.5 billion people is not enough. It's way too much. Different podcast. But we're taught, okay, great. So sex is to continue the species. That seems like the most paramount thing. And then the fact that it feels good should be secondary, particularly because this big book that hundreds of different people wrote that can't be verified or whatever, this book has been telling us, people have been telling us that sex should not be about pleasure, should not be about bonding.
Yeah.
When we all know that that's the reason we like it so much, right? Because it feels good. And we have not been taught to center our pleasure. We have not been taught, particularly as like queer folks, as Black and brown folks, as poor folks, right? I live in various states of degrees of a fat body, right? I have my entire life. So fat, Black, queer folks, we're not, please, are we ever allowed to center our pleasure, right? Or even the responsibility that we think that, let's say, a 19-year-old or a 21-year-old might have in understanding what is pleasurable for them. No. You're too young to understand that. You can't. And especially exploring that with someone else. So rather than going through the lens of you're having sex, hopefully you're having sex with yourself so that you know what feels good for you.
Yeah.
So you're having sex. Let's arm you with all the tools and knowledge you need so that you can go out there and have like the best damn sex possible and the safest sex possible. No, instead we're just going to like do things like they do in other parts of the country, right? Where they don't talk about this, or abstinence is the only education that's provided in school systems, or, you know, it's through a really intense religious lens. It is almost always through a heteronormative lens, right? So yeah, I mean, clearly that quote fires up a lot in me, right? But I think that's part of the reason why we have the conundrums that we have in terms of people not being comfortable being open and communicative about STIs and HIV and sex, because we're always taught to squash it down. We're always taught that it's a bad thing for us to feel good about it, or just want to like have sex for sex sake rather than for procreation's sake, which if you hyper-focus sex on procreation, you automatically dehumanize anyone who has sex that can't procreate. Like,
oh, totally.
All of us queer folks.
Yeah.
Right? Not all of us. Most of us queer folks. Right?
And not to mention, I mean, if you talk about looking at it biologically, a lot of people who are, let's say, anti-queer will say, like, oh, we have to look at this biologically. It's like, okay, if we look at it biologically, there are a lot of points to be made, but the amount of times a person will have sex in their life for pleasure is hundreds or thousands of times, whereas the amount of times a person will have sex in order to procreate will be between 0 for a lot of people and like 3 or 4 max. In the United States, it's less than 2, or the average amount of children any given family has is like 1.9, so it's less than 2. Right. So if you look at the significance of that data, biologically speaking, it points to this idea that sex should be regarded first as a bonding device because we're social animals, and it's one way that we create social bonds, which
100%.
is the most important thing we have, right?
It seems like such a weird phenomenon to have this really intense, significant part of ourselves, including people who are asexual. It is a significant part of their life that they are not sexual, because we are in as much as it's puritanically from a religious standpoint, sex should be about procreation, right? That's what we learned. We are also in a hypersexualized environment, particularly for cisgender women, right? And so even asexual people, like, sex is often at this like forefront. And I think is really interesting that it's such at a forefront, but it's also taboo. It's such a forefront, but we can't talk about the diseases with it. It's such at a forefront, but we can't talk about that. I like to use a 1 to 10 scale rather than a Kinsey 1 to 6 scale.
Okay.
Most of us fall somewhere between 3 and 7. Most of us. But we all want to live at the 1s and the 10s, right? Especially like, agro, bro guys, like whatever. And not to overgeneralize them, but most of them are not 10s, right? Most of them are somewhere else on the spectrum, but we don't allow for that. So I think it's so funny that we all have this really intent part of us, the sexual part of us, that then we don't actually get to acknowledge as something that helps us bond, something that helps us connect with someone, that you really can have an intense connection with someone sexually, even just for one night, and it can actually be really meaningful, and then you can never see that person again.
Right. Which is so this is changing, right? We're talking about cultural dynamics that contribute to stigma around sex and stuff like that, sex and sexuality. What I love about the work that you do is that you're, as a healthcare professional, using the information you have, presenting it to people in a fun way, and in a way that's not scary to talk about sex. However, apart from that, the healthcare system in general, there are barriers to a person speaking with their healthcare provider about things like sex. So I heard you say in an interview once that 50% of patients are uncomfortable bringing up a health condition with their primary care provider. That's crazy to me. But I also think about my own experiences in healthcare offices and why that might be the case for someone to be inhibited somehow for some reason to bring up health conditions to a healthcare provider. And so I want to give an example, if that's okay.
Sure.
Let me see. Okay, so I went to a healthcare office recently, and it was a negative experience. And I went home and I was like, dang, like, I don't feel very good right now. And so what I did in the moment was like, I'm sure I'm not the only one. Let me Google this phrase, lack of compassionate care in healthcare. And a lot of content came up, and I even saw some studies that relate avoidable deaths to lack of compassion in healthcare. And so this is a phenomenon that happens in the US. I'm sure it happens in other countries, but I feel like it's very strong in this country. And I also know that there is a movement within healthcare to fight this phenomenon of doctors and nurse practitioners and nurses as well, who want to bring the focus back to compassion for a lot of reasons, but maybe one of the reasons is to do away with these avoidable deaths,
100%.
or so that this number of 50% of patients feeling uncomfortable speaking to their primary care provider goes down in a big way. You contribute to this effort to do away with the lack of compassionate care in healthcare. I wanted to just hear you talk about this phenomenon in general.
I mean, I hope I contribute to lessening it. Thank you.
Definitely.
That's kind of the point of Ask the NP and the work that I do, and talking on podcasts and TV and radio and all of this stuff. I mean, listen, we could have a podcast series about this, right? Like, I could talk about this for forever, because there are there are a lot of structural issues in healthcare that prevent otherwise well-meaning providers from being able to provide compassionate care. Primarily capitalism, right? I'm not a genius in bringing this up. Like, we can sort of blame almost everything on capitalism. But if you are a provider in a clinic who maybe has to see to help keep your clinic doors open, so maybe even in an altruistic standpoint, like in the doing the best you can for the most people standpoint, you have to see 27 patients a day in 8 hours just so that you can bill enough to keep the doors open so that this community has a clinic. Okay. I'm oversimplifying, but humor me. So if that's your focus, then if you have 12 and a half minutes to see these 27 patients or whatever, do the math, you aren't having time for compassionate care, particularly because almost all of us, particularly after COVID, are coming in super sick. We've got lots of things going on. Rarely is someone going to a clinic and they're like, my knee hurts. They're like, my knee hurts and my hemoglobin A1C is 15. And oh, I actually was at an orgy this past weekend and I'm interested in DoxyPEP or something like that. Like I ran out of my HIV prep a week ago. Am I still covered? My grandma's dying. I'm actually so anxious that I can't even get my job done, right? And I think I'm going blind in my right eye. That's the typical patient, right? Most patients come in with lots of things. So if I've got 12 and a half minutes to see you, even in a standpoint of, and this is not making excuses for the system, but more actions of individual providers.
Yeah.
Might just be like, okay, oh my God, you're going blind in your eye. Like, whoa, let's address that first. And then let's go, okay, let's talk about DoxyPEP. Okay, let's talk about your HIV prep. Okay, let's talk about this stuff. We really got to talk about your insulin, blah, whatever. And then the next thing you know, your 12 and a half minutes are up and you've gone, they're kicking you out, or the provider's moved on to the next person and they haven't asked you one question. There's so many layers to so much of that that's going on that it's really a function of a really antiquated, really, really bad system.
Yeah.
And that's in a clinic setting. In the hospital setting, it can sometimes be even worse. And so most of us go into this profession wanting to help, we care about people and we want to ease suffering. And it's hard to do that in the confines of this system. And then what ends up happening, and it happens to me, I'm just as guilty of this as anybody else. The system starts to wear on you after a while, and then you just become less of a compassionate person, and you start not seeing people as people.
Yeah.
You're just seeing them as diagnoses.
You have to compartmentalize.
Totally. To protect your own mental health and things like, especially during COVID, that was a whole thing. So that on top of the fact that medical education, and the people who are MDs and DOs might get mad at me watching this, but medical education has not always focused on care of the whole patient. It's very disease and diagnosis focused, which we need. I love the physicians that I work with. We need them to have been disease and diagnosis focused. But what happens with that is they pop out into practice and they haven't learned that, oh, I'm not taking care of diseases. I'm taking care of people who happen to have diseases.
Yeah.
Rather than nurses who tend to be more human and person focused. And then we need help figuring out the diseases and the diagnoses, right? So we sort of, this is why we all work together really well as a team. But until we fix medical education and nursing education and the entire system, there is a lot of this that is just rooted in it and hard to break down. And so this is the why. Not an excuse, right? It's a different energy, but this is a why so many of us, myself included, have just really shitty experiences at our healthcare provider, right? We're like, man, not only I get nervous to talk to my doctor. I see a DO. He's fantastic. He's gay. He's great. I get nervous. And I literally do this every day. Like this is what I do for a living. I get nervous going in to talk to him. So a couple of things, I always tell people to write things down.
Okay.
Keep a notebook. I actually don't even like it on your phone. I keep a physical paper notebook, even if just for that session, and then you can go back and document it electronically later. Write things down in a notebook that you want to cover. As soon as the provider walks in, remember, you're the boss. You're in charge. Hey, Dr. Simmons, I'm really glad you're here. I know it's been 8 months since I've seen you. Here are the 3 things I really want to talk about today. Good providers will say, oh, that's awesome. Thank you. Let's talk about those 3 things. And then, oh, by the way, Zef, I have 2 things I want to talk about too. Do you think we can get to 5 things in 15 minutes? Sure, we'll do it together, right? Then all of a sudden it's fun. It's a conversation, right? And we're focusing on you as the patient.
Ooh, yeah.
And listening to you, which is really the biggest thing I think is we as providers just have to do better, is just stop, breathe, listen to people. They will tell you what they want if we're listening. And then the other thing I would just offer to people too in that sort of environment, like what you were mentioning, is that part of that 50% of people being scared is because people feel like they have to use our language and talk like us to describe their symptoms. No. It's actually the opposite. We want you to come in and use whatever language you want, because we're the ones that went to school for years and years and years to be able to help you decipher what that means and figure it out.
Right.
So you don't have to have a medical education and come in and talk like I talk for me to understand you. In fact, it's quite the opposite. I don't want you to try to use big medical phrases, and I don't want you to feel like you have to. I want you to feel like, sometimes when it feels like I have to fart, but I'm not farting.
Yeah.
But then when I don't, the pain moves over here, and it's sort of like someone punched me, but not really. But like if I was laying on my dog's collar, great. That's a beautiful explanation of abdominal pain.
Yeah.
I will be able to figure out what's going on from that. Does that make sense?
Totally. Yeah, I think part of it's a systemic problem. It's also this cultural message that says like, okay, your health is in the hands of the healthcare provider, which obviously they play like a huge role, but there also needs to be some agency, some personal agency on the part of the individual to know about their own health, to be in touch with their body, to be able to express in whatever way is appropriate for them, how they're feeling, communicate that with their provider.
Which is why I love like younger generations, by the way, like the Zoomers approach this totally different. They walk in and they know that I am here for them. And I love it. It's great. And they're like, no, we're talking about this. I want this. They're like, I'm not worried about my A1C. We need to talk about that later. Whereas I'm as a provider, I'm like, well, your A1C is a little high. Like I want to talk to you before you do like full blown diabetes, right? And they're like, we'll get to that. Cool. I float on cloud 9 when that happens because that means this person is really hyper focused on and feeling empowered to take charge of their own health. Cool. That means that person's going to come back to my clinic in 3 months.
Yeah.
And at that time, then I'm going to be like, okay, Jessica. Now
we're going to circle back to
this. What's your list? Let me see your list. Let's talk about your things first, but you got to humor me. We got to talk about this one thing. Okay.
Yeah. Very cool. So things are changing. That's good to hear.
Slowly.
While you're here, and since we're coming up on time, I wanted to take advantage that we have a nurse practitioner with us. So I have a question about DoxyPEP, if you could help us out here. So Doxy is short for doxycycline. Doxycycline is an antibiotic that's used to treat bacterial infections, as far as I understand. So recently, I've been hearing about this in the past like year or two, that about DoxyPEP, so post-exposure prophylaxis, when we're talking about sexually transmitted infections. So let's say gonorrhea. Let's say a person thinks that they were exposed to gonorrhea or knows that they were exposed to gonorrhea. They have a 72-hour window in which they can begin a DoxyPEP treatment to avoid the exposure turning into a transmission, right? To avoid getting gonorrhea. I've heard healthcare providers also express concern around the habitual use of Doxy, saying that there is a potential, although none of these claims are based in scientific evidence, that your body could build up a resistance. So to be careful, because your body could build up a resistance. If you're taking DoxyPEP and you haven't been exposed to gonorrhea, your body could get used to the antibiotic. And then should you be exposed to gonorrhea for real, then the DoxyPEP, having adapted to your body, might be less able to fight off the gonorrhea. That's part one. And part two is I looked on the CDC website, and they are talking about Doxy as prophylaxis for malaria if you live in a region that has a malaria season, or if you're traveling through a region with malaria. This is language from the CDC website. The CDC has no limit on the use of doxycycline for prevention of malaria, meaning that it can be used as a prophylaxis throughout the malaria season, so like for months on end. My question to you, Dr. Simmons, is what do you think about that? Like, keeping that in mind with malaria, when I'm thinking about DoxyPEP for gonorrhea, say, how should people be approaching this?
Incredibly thoughtful question, Zef.
Thanks.
I love it. That's awesome. I guess I'll just come out and say right away, I don't want people to be scared to use DoxyPEP whatsoever in terms of resistance patterns. So resistance patterns, that's medical talk for, is this antibiotic, to your point, going to stop working against these diseases because we've used it too much? So mini science lesson for those listening. Bacteria's job, its really only job, is to stay alive and reproduce. Okay. And so this is why bacteria propagate, medical term for grow, and spread to other people. They like new, warm, moist holes, right? That's their job as bacteria. So in order to stay alive and reproduce, they learn about the things that kill them. Okay. So just like we as humans learned, like, oh, we can't like drink more mercury, or like, maybe lead is not great for us, right? Because it was killing us. So we stopped using lead, right? We adjusted. Bacteria do the same thing on a literal microbiological level. So that's why some antibiotics work really, really great against some bacteria for a while. Kill them, kill them, kill them. And then the bacteria learn, and all of a sudden the antibiotic doesn't work. It doesn't kill it anymore. Now, certain bacteria and certain diseases match up with certain antibiotics, okay? Some of the sexually transmitted diseases that we have, gonorrhea is the biggest one so far that's getting the most, like, I guess, media about this, are starting to become resistant to almost all of the antibiotics that we have. Almost being the key word. We still have antibiotics that will kill gonorrhea and chlamydia and syphilis. Pretty easy, okay? When it comes to gonorrhea and one strain of gonorrhea, we are down to one antibiotic, okay?
That's the concern, right? It's like we don't have a lot of defenses against gonorrhea, so we gotta...
So gonorrhea is kind of the one, like, we really only have ceftriaxone anymore. Like, that's kind of it.
Yeah.
Now, ceftriaxone is working really, really great. We have no evidence in the literature so far that would lead us to believe that ceftriaxone, it's a shot, it's the big shot in your ass, right? We have no evidence that that shot is going to stop working against gonorrhea anytime soon, okay? It works great, but it's kind of the last one for some strains of gonorrhea. So with that thinking, I set you all up with that, because with that thinking, Doxy or doxycycline works so great, particularly against syphilis and chlamydia, and it's okay against gonorrhea, it's okay, that we don't want to end up in another situation where all of a sudden, all three of those, the three of the four most common sexually transmitted infections, we get down to only one antibiotic, and then maybe that one's going to stop working. So that's the prevailing thought. Now, that being said, we're not close to it. Syphilis is not the same in terms of a response to Doxy as chlamydia, as gonorrhea, okay? And it is far and away better for us to prevent these exposures turning into transmissions at this point than it is for us to worry about antibiotic resistance. Now, I think this is going to be a little controversial. I think it is important for us to keep antibiotic resistance at the forefront, for us to honestly think about this. And so if you are someone who finds that you are needing DoxyPEP every week, that's a categorically different scenario than 90% of us, and that is my statistic, okay? I don't know. I'm just throwing it out there. 90% of us who might need DoxyPEP 2 to 4 times a year, okay? That's different. Oh, I'm going on an Atlantis cruise this weekend, right? That's the classic example, and that's a great example.
Yeah.
But if you are also like, wow, I took that 200 milligrams within 72 hours of exposure, that's the DoxyPEP prescription. I took it on Monday. Well, I need it again on Thursday. Then I need it again the following Tuesday. Then I need it again the following Thursday. If that's happening to you that frequently, there are other ways that we can talk about preventing specifically syphilis, gonorrhea, chlamydia, and of course HIV in your sexual practices. I want you to keep fucking. I want you to keep getting out there. I want you to keep making it do what it do.
Yeah.
But if you're that individual, we should have a conversation about how DoxyPEP lives in your world, right? That for you, that could be an issue. Most of us don't have to worry about that. And so my big message to folks is it is a fantastic tool. So far, the data is really only in men, cisgender men who have sex with men, and trans women who have sex with men, or trans women. But data is coming out about cisgender straight folks.
Okay.
To also use DoxyPEP.
So we're going to close out this conversation, which, by the way, I've been enjoying very much. But I think there's also another point to be made that you see a lot of billboards that are like, oh, drug-resistant gonorrhea, watch out for it. And I think that it's an important message, but the nuance there is like, it doesn't exist yet. We just need to be careful. Like, if it gets to a point like the point that you're describing, talk to your nurse practitioner or ask the nurse practitioner.
Well, and I'll give you, it's a multiple truths exist simultaneously. It's one of my favorite phrases. I just said it to a patient this morning. Multiple truths exist simultaneously. Most of the gonorrhea that's going around right now is not the super bug gonorrhea that you hear in the media.
Yeah.
It's not the, oh my God, antibiotic resistant gonorrhea. You're going to die. You're going to have to be in the hospital for 6 weeks on IV antibiotics. That's not the gonorrhea that's going around.
Yeah.
But that gonorrhea does exist.
Yeah.
And it has been being transmitted sexually. So should you freak out? Should you panic? Should you fall prey to the clickbait of it? No. As a scientific and medical community, do we really need to be on top of this and watching it? You bet your ass we do. And we need to be better. To your sort of overall point of our discussion, we need to be better about how we communicate this to folks. Because I also know people in my life who are like terrified to have sex because they're going to be the one to get the one strain of the super gonorrhea that we can't cure, that's antibiotic resistant to every antibiotic. Okay, probably not, right? It's just like I am a terrified flyer, but I fly all the time. But I'm always convinced that I'm the person that's going to die.
But the likelihood is so minuscule.
It's small, right? Yeah. So I love you used the word nuanced earlier, and I think it is important to understand that this is a little bit nuanced, that super gonorrhea exists. The theoretical possibility of doxycycline not working down the road, that theoretical possibility, sure, it exists. Is it our reality right now? Is it most people's reality right now? No. And we need to be okay operating within this reality.
It's a good message for like approaching lots of different things is like keep the risk in mind, but don't freak out. Like everything's going to be okay.
And by the way, just heaven forbid me being this person, but if you are scared, barrier sex is
condoms still exist. Yeah.
And it's making a comeback a little bit. Yeah. I understand.
I mean, I don't know if I go that far. But
I know people don't love it, but I'm just saying.
No, but yeah, condoms are still an option, and they're an excellent option. Yeah. Okay, Dr. James Simmons, thank you so much for being with us today.
Thank you for having me.
You can find more of Dr. Simmons at Ask the NP, N as in Nancy, P as in Peter, on YouTube and Instagram. You're really big. Are you active on other platforms?
I am. I'm on Twitter, X or whatever it is now. Although that's just more, I just sort of disseminate information. And I'm working on this TikTok. I think I'm doing okay. More to come on TikTok, but it's all the same at Ask the NP.
Okay, you heard her here first. There's more to come on TikTok. And thanks so much for being with us today, listener, viewer, and we'll see you later.